Okay. The board has met in closed session. No action was taken. Direction was given to staff. We will now have time for citizen comments. And no individual signed up. Is there anyone in the audience? Okay, no citizen comments. Now we'll move to our discussion items, starting with the presentation from Alliance Health. And we have Kelly Goodfellow, who is the Executive Vice President. Joanne Pierce, our Assistant County Manager for Community Wellbeing. And we have allocated 30 minutes for this presentation. Will 20 minutes for presentation and 10 minutes for questions be good?
That will be sufficient. We have one more party coming just before we can start.
And when you're speaking, just make sure you turn the mic on. Yours is on, but yours are off.
He is. He just stepped out. Unfortunate timing, stepped out.
Go ahead. Good morning. Good morning, commissioners. Madam Manager, it's good to be with you. I'm Rob Robinson. I'm the CEO with Alliance Health. I have with me this morning Kelly Goodfellow, our Chief Financial Officer, Sean Schreiber, our Chief Operating Officer, and Ann Osho, who's our SVP overseeing community health. Again, we're with Alliance Health. For those that are new or may not remember, Alliance Health was formed out of a merger between Durham County and Wake County back in 2012. The Durham Center was the local mental health agency, and we started as a service provider, then transitioned to a local management entity before merging with Wake County. I'm pleased to say that all four of us actually worked at the Durham Center. I started there in 2002, and these folks have been there almost as long. And we're proud of the work that we've done at the Durham Center. We've done some really creative, innovative things in partnership with Durham County. Pleased to say that many of the things that we created over the years are still in existence. So we do have a presentation this morning. I'm going to kick it off, talk a little bit about Alliance Health. Kelly's going to give some financial numbers. Sean's going to talk about services available in Durham County, and then Ann's going to take us home with a presentation on our work in our community. So, Alliance Health, we are what's called a local management entity, or LME-MCO. We cover 7 counties, Mecklenburg, Durham, Wake, Johnston, Orange, Fayetteville. What am I missing? Harnett County. Sorry, we're growing here, and I've got to remember all those. LME stands for Local Management Entity. That's about managing behavioral health care for people who are uninsured, underinsured. MCO, of course, stands for Managed Care Organization, and that's about managing care for people with Medicaid. We service about 190,000 people with Medicaid over a population of 3.5 million folks. We do have an office in Morrisville. It's located on the border of Wake and Durham County. That was actually part of the merger agreement between Wake County and Durham County over 12 years ago. We also have local offices in Fayetteville, Smithfield, and Charlotte. We do have a staff now that says 1,200. I think we're approaching 1,400 staff. When we were the Durham Center, I think we had about 65 staff. As a reminder, we are not a service provider. We manage a network of behavioral health and physical health providers across our catchment area, and that includes just about all the hospitals and health systems across the state. And we began operating a tailored plan in 2024, and I'm going to talk about that in just a moment. So here's a map of the LME MCO regions. We are the pinkish, orangish, mauvish color in the central part of the state. You can see that we have the smallest number of counties, but we are the largest of all 4 LME MCOs by population, primarily because we serve mostly metropolitan area. To give you a little context, when we started this, there were 43 of us. We are now down to 4. All right, Taylor Plan. We are excited about that. Taylor Plan is part of the largest change in North Carolina healthcare in its history. A Taylor Plan is one of 2 types of Medicaid plans in the state. The other is standard plans. There are 5 in your catchment area. What's different about the Taylor Plan starting July 1st is that we are now responsible for operating a fully integrated care, meaning we're responsible for managing physical health, behavioral health, and the pharmacy benefit for people with serious mental health, serious substance use, everybody with an intellectual and developmental disability, and folks with a traumatic brain injury. We are also still responsible for managing care for people who are uninsured, underinsured, using county dollars. The way we describe it, we are responsible for the care for the individuals with the greatest needs in our 7-county region. All right, with that, I'm going to turn it over to Ms. Goodfellow, who's going to give a budget update.
Good morning. Once again, my name is Kelly Goodfellow. I'm the Chief Financial Officer for Alliance. Thanks for giving us time on the calendar today. We certainly want to take the opportunity to review the financials. We're entrusted with public dollars and want to make sure we communicate and are transparent to our stakeholders. The first slide is our fiscal year 25 budget. You can see that it is $2.193 billion. This represents an increase of nearly $800 million from fiscal year 24, and this is due to the Taylor Plan. You can see the Medicaid dollars at the top accounts for a majority of our funding at 78%. These are the dollars to cover both the physical health and behavioral health services in all 7 of our counties for our Medicaid members. The next line is the federal and state dollars that we receive for our uninsured and underinsured members. The next line is all our local dollars that we receive from 6 out of 7 counties in our area, and that is for services in those respective communities. The next line is our administrative function, and we make a concerted effort to remain below 10%. The next is Taylor Care Management. As Rob mentioned, that is the services we provide to our members, and there's revenue tied to that we receive. And the next line is just other items such as grants, other business items, and so forth. This next slide may look familiar to you in terms of the numbers. This is the fiscal year 24 budget for the funding agreement with Durham County. These are dollars set aside for specific services and programs within our county, and we contract with providers for those services. As we move into this slide, I recognize there's lots of numbers, so let me take a moment to just orient you. To the left is the programs, as you saw on the previous slide. The next column is the fiscal year contract, again, as you saw on the previous slide. The next column is just the spend as of July 22nd. Like you, we're in the midst of closing our books, and so we may have some remaining invoices that may come in before the end of the year. The next column is our remaining dollars, and the next column is our projected spend. All the way to the right, you see the projected underspend amount, $5.7. This is $5.7 million. That is money we have remaining of the 6.5. We're going to go into a little more detail of that in the following slides. Rob is going to go into how the impact on spending this year and how we can prevent that in the future. Just a small note about the second line system of care. That small blip occurred. We had a staff vacancy that has now been filled. Again, and Rob will talk more about this, we'd love opportunities to partner with the county to expand services within the community. We have done that in other places and certainly welcome that opportunity to do that in this county with the remaining dollars.
I know you're going to go into this, but if you could really just right now respond to Recovery Response Center, because obviously that's pretty dramatic. What is that? going on there.
Yeah, and that is not to say services did occur. This is just we did not use the dollars because of state dollars we had available to us. So absolutely, they were in business, served members continuously. This is just the fact that we had dollars available to us from the state to be able to utilize. We do have a slide to that. Would you like me to skip forward to that? Okay. Yeah, the state, there's an abundance of state dollars, and there's a few other things that impacted our use. Okay. Just for historic context, we have historically used our county dollars fully, and this goes all the way even back to fiscal year 13, since we've been in existence. COVID was the blip, of course, on the map and changed the trajectory of spending in those 3 years. In that time, during the COVID years, we received $22 million from the state to provide care for the under and uninsured. That meant that we could use those dollars before we used our county dollars. All our local funding agreements require that we use all state dollars first before we use the county dollars. And because of that abundance in dollars, and we got that on the Medicaid side, but for the uninsured side, we were able to use all those dollars and not go into the county dollars. Again, all the services continued, it's just we were able to use other funding for those services. We did partner with the county, and we were able to use $400,000 of those dollars remaining for bridge housing, and that program has opened, in fact, is opening this week. So I'm going to turn it over to Rob, who's going to get to Commissioner Jacobs.
All right, so Kelly had talked about this year we did not spend all of our county dollars this year. All services were provided that were in the contract with us to spend. Let me talk a little bit on why the money wasn't spent and then what we're going to do about it. So first was Medicaid expansion, which of course is a very good thing for this state. It's been a long time coming. There are hundreds of thousands of people now that have a payer source to pay for any needed physical health and behavioral health treatment. So we celebrate that for those people that got those services. However, it did decrease our spend on the state and county funded side, which is one of the big reasons why we didn't spend our county dollars. We also have a workforce and provider capacity issues. I quite frankly think this is a crisis across our state. We have an extreme shortage of workers to work with people with behavioral health and IDD needs. Provider capacity, we've lost several providers because they haven't been able to receive the funding and generate the revenue they need to stay afloat. The state has developed a plan that's in the midst of being implemented to help address the workforce shortage. Alliance has also done our part. We have increased rates. We've made one-time payments to providers. We hope that money would help stabilize the provider community, and a lot of that money used to increase staffing, salaries for staffing, and also helping their recruitment and retention efforts. We also got extra money from the state, right? So we got extra money from the state that we typically, of course, get that towards the end of the year, and then that would also help in preventing us from spending all of the county dollars. Come on. There's no more buttons to push. Is that it? All right, got it. Thank you so much. All right, so what are we doing about it, right? We see this as an opportunity. We didn't get to spend all of our county dollars. This is not unique to Durham. This is not unique to Alliance. This is across the state. There's been leftover money in much of our catchment areas. Because of the generosity of the counties that we serve, we've had the most leftover money. So we're using this as an opportunity, and we've already taken action. One of the things we're doing is matching state rates to Medicaid. If you looked at our budget, there is extreme difference to what's available with people with Medicaid versus people that are uninsured, underinsured, using state and county dollars. So we have made the decision to increase the rate on the state and county side to match that with Medicaid, right? We also have several services that are only state funded. They are not provided by Medicaid. Medicaid, we've also increased the rates by 5 to 25%. We've heard from our providers. They are extremely grateful for us for doing that. Hopefully that'll help stabilize the system. Still more work needs to be done about developing sufficient workforce, but we think these efforts are going to help. The other thing we're doing is evaluating our state benefit plan. As I said, because of the discrepancy in the amount of money we get from Medicaid versus state and county, you don't get the same level of service that you get with Medicaid. However, we are evaluating that with this additional funding that we have. We're going to try and match as best we can the state benefit versus the Medicaid benefit. For example, under the state side, we may only be able to afford 6 outpatient visits, right? Medicaid, you can get 10 to 12 visits. We're going to try and increase those allowable hours from 6 to 10 to 12, right? ACT is another one. We've had to cap ACT services, Assertive Community Treatment Team. That's an enhanced community-based service for people with serious mental illness and substance use. We have had to cap the number of slots we can offer. We'd like to expand that slot. So more people with the uninsured, underinsured will be able to receive that service. All right, so that's what I just talked about, increasing the benefit package, increasing rates. We're going to do across our catchment area. For Durham specifically, we've identified a couple areas through our needs and gaps. We've also identified some items that through talking with Commissioner Carter about what you all are seeing in your community. The first thing we'd like to take a look at is increasing supportive housing for people with mental illness and addiction issues. We're also talking about increasing day services, either through a rate increase or opening up more options for people with mental health. This will allow people to have something to do during the day with support. For example, one is Threshold. We'd also like to support some of our nonprofit organizations that are struggling, that serve people with mental health and addiction issues. And then lastly, increase medications for people with uninsured, particularly that need opioid treatment. So these are the things that we're looking at. We are going to make decisions very soon and then hopefully implement shortly thereafter. And I think you'll start to see a difference in what's become available and what's been expanded in this community. All right, I'm going to turn it over to Mr. Schreiber to talk about what's available in services in Durham.
Great, good morning, and thank you for having us here today. Again, my name is Sean Schreiber, the Chief Operating Officer. I'm going to provide a small overview of some of the services that are going on in the community, spending a little bit more time talking about some of the opioid treatment that goes on while this is still a raging crisis. I think when we think about the ideal setup for any community, Durham really has probably the gold standard for the state of North Carolina and how people can access opioid-related treatment. So I want to spend a little time talking about that. So as Rob said, this year we've become a tailored plan, and in the past we've always been responsible for setting up a behavioral health network. Now we're also responsible for setting up a physical health network. So hospitals, surgeons, pediatricians, pharmacies, kind of you name it, the whole gamut. We're really pleased to report that in Durham we meet 100% of the state's tailored plan network adequacy standards. Most of those are time and distance, so in honesty that's not the highest bar, but the second part now is we begin to evaluate when people go, how long do they have to wait? How long do they have to wait to get an appointment? That's the second way we'll begin to examine if our network is sufficient. But as of today, it is meeting all the contractual requirements. A big deal for many years in Durham, if you were uninsured, and for the most part, even if you had Medicaid, there was one option to get methadone treatment at a licensed opioid treatment clinic. We've been able to expand based on some of the kind of new funding that's coming to the state and Medicaid expansion. We've been able to expand that, and now we have all 3 of the opioid treatment centers in the county are now covered by Alliance for both the uninsured and insured individuals. And that's really been really important important because a lot of individuals come out of certain situations without having insurance. It takes a while to get it turned back on for people who go to jails if they've been in a state hospital for a long time. So now individuals who are uninsured and people who might have received the gap can make sure there's no break in that care. And again, I'll talk a little bit more about it, but Durham's done a really nice job, the providers, the crisis system, Duke Health, in making sure when they intersect with someone who's had opioid use disorder that they're starting them on medication-assisted treatment, which is really the gold standard for that disorder. A couple of other things. We've implemented some new services for children and adolescents with more complex needs. The state has always had an adult mobile crisis service, and it's okay. It's always been one we've been kind of working on tweaking as a 2-hour response time, but really that model is someone's in a crisis, they call our call center, we deploy a team, they go and stabilize and refer to a provider. This more specialized service for youth can be if children are kind of moving to a crisis or families moving to a crisis or they're having one, but child might be taken into DSS custody. They go out, they have a worker comes out, does an assessment, does a support assessment, but then they stay with this family for up to 8 weeks to make sure the crisis is abated and that they're really strongly connected to other services. A big challenge in the Medicaid space is, you know, if we get people access, there's a lot of barriers, and so getting those people to be engaged and put all the things you need in place, like maybe transportation, maybe child support, finding a pharmacy, you know, that's local that can fill prescriptions, all that takes a while. So we're pleased to have that more comprehensive support. And then opening this week is a crisis home. That was really a partnership between the County Alliance and a provider called Breakout. As you've probably been seeing, and you may have heard from your own departments of social services, there is a crisis in this state and actually across the country of foster parents kind of moving out of the system. The needs of children tend to be beyond what the historical residential services could provide. So we began partnering with the various counties to open very specific short-term crisis transitional group homes where kids can come if they don't really have a place to go and get a good comprehensive evaluation, some stabilization, and then be referred into a needed level of care, or potentially, if things stabilize enough, go back home with support. So that home opens this week. It's gone through licensure. Finally got enrolled in Medicaid. Like every time you think you've done a hoop, there's one more, but all the hoops, all the bureaucracy around it is done, and they should start admitting this week. And the other thing that we're doing in Durham is there's a particular service that's aimed at individuals with more significant mental illness who tend to be in and out of the crisis system, tend to be in and out of homelessness, and we've helped a provider develop a specialized team that's really focused on working with individuals in the justice system. So someone goes into detention or jail and they maybe have a mental health diagnosis, this team can link with them and begin providing supports, and this support can go on as long as the person needs it, so it's not time limited. And just a couple statistics. You know, I probably should have done a better job of putting rates, but last year through the Alliances Network, about over 16,000 people received services, and that's a combination of people with Medicaid and uninsured. I've put up here, and one thing that's important at Duke is providing integrated care management. One of the hallmarks of the tailored plan, the specialized plan for our folks, was that every member is supposed to have a comprehensive care plan and a care manager assigned to them. And it's a little fragmented. The way it works at Duke, though, people who are in primary care, our members who are receiving their primary care from Duke, for the most part, get care management. And so because Duke is on Epic, that means if one of their members who's in primary care shows up at the hospital, they know it. The care manager can be alerted. They can put a bunch of things in place. And I think Duke is maybe one of only 4 providers across the state that elected as a big primary care and health system to join in and do tailored care management. And they're probably having some of the best success so far doing that. So we're thankful for that partnership. It talked about some of the work around opioid use disorder. In those 3 licensed treatment providers, 568 adults receive care. What that doesn't include is Durham also has office-based opioid treatment that we fund for the uninsured, and so there's a large number of individuals who receive that, and we're able to use some of our other funding to cover things that typically Medicaid would cover, the cost of medications and lab expenses. Also, if an individual goes into RI or recovery crisis center in the county, and they have an opioid use disorder, they're started on medication-assisted treatment while they're there and transition to the community. We've also partnered with Lincoln to make sure if our members go, that we pick up the price of the copay for the medications that they've had. So we've really done a nice job of setting the bar low as far as access. There should be very little an individual needs to do. And of course, the detention, I think maybe in Durham Detention was one of the first detention centers in North Carolina to begin offering treatment. Our job is to make sure when people get out, they get linked and can get access and pay for that. And part of that is through our partnership with Girlies as well. So you give us some funds, we put in some funds, and people without insurance then can get these money at no medications at no to little cost. And if there's no questions, I'll turn it over to Ann Oshel. Thank you.
Good morning. I am mindful of the time because for those of you that know me, I could sit here for the rest of the day and talk about kind of the importance of the work that we do in the community. When Alliance became our organization and separated from the Durham Center, we promised that we would maintain local presence, and we have kept that promise. We have staff that are dedicated solely here in Durham County to understand our partnerships, to understand the needs of the county, to offer improvements to access to care, to help people understand how you access care. We are a very complicated system now, between standard plans and now tailored plans, and who's on Medicaid at any given moment and who's not, who appears before the courts needing access to services, and how does that happen. And so in Durham, we have a criminal justice specialist that is dedicated. We host crisis intervention teams still here in Durham County. We have a member engagement specialist. All of our system of care staff is dedicated here in Durham. And then we have a community education specialist in Durham. And one of the things that we've done in the last year in particular is have all of the work located in our counties supported by a broader team that is focusing on housing, that is focusing on other social drivers of health. And I'll talk a little bit about where we are in that. So we continue to do the things that we've always done here, member outreach and engagement. Some people need to be accompanied to understand their benefits, to around financial literacy, health literacy, managing all the different doctor's appointments, access to pharmacy and other benefits. And so we have a team that works directly with our members who have the most complex needs, who might be transitioning out of hospitals and other institutions, to get connected to services, connected to wraparound supports. This team and the position here in Durham is someone with their own lived experience and are in recovery. So they also understand kind of how you navigate the stress of homelessness or housing insecurity coming out of a hospital or a jail and maintain your recovery. Community education, mental health first aid. Last year when we were here, we talked about how we had trained the entire library staff in Durham County on mental health first aid. We continue to do that. We've trained a whole network in the faith community around mental health first aid. We also have an access to care presentation that we market widely so people understand what care and coverage looks like and what to do if somebody is dropped from a health plan. Part of that is also understanding how you access the crisis systems. That is the one kind of equal opportunity. We don't ask for insurance. We don't ask, where you live. If you are in crisis, we help you get to the right level of care. And then all the system of care work, our family partner, our system of care coordinator, our community collaborative, all of that continues here in Durham, where we have prioritized kind of two community efforts, and that reflects one of the shifts of how we think about care for people. You've heard us talk about access to treatment. People need ACT teams, they need methadone treatment, they need all kinds of treatment, but we also treat people who live in complex environments. And we know that people staying medication compliance when you're living in a camp or under a bridge is less likely. You remembering to come to an appointment is less likely. And so we've had 2 partnership and funding efforts over the last year, and that is to expand our housing efforts and all the work that we do on social drivers of health. So last year, we put over $200,000 into community capacity grants. In a minute, we'll talk about the healthy opportunities that will also have quite a bit of Medicaid funding. But this is really to engage nonprofits who have never worked in the Medicaid space to understand what it's like to have Medicaid as a revenue. And so we have convened food insecurity roundtables. We did a round of funding for some food insecurity nonprofits. We learned a lot. They learned a lot. And all of this is anticipation that Medicaid will soon become a payer of food and housing insecurity. And so while Durham or any of our other 7 counties are not part of the Healthy Opportunity Demonstration at this point, we want to pretend as if we were, and to offer some funds. And the nonprofits that received these funds did some really creative things like mobile food delivery. We also launched a food and nutrition program. We have a contract now with a vendor called Nourished RX that is a food delivery service. So for people that are coming out of longer-term institutional care, living in the community, these are people who've never made a sandwich, much less understand how you go to the grocery shopping, how you eat to control your diabetes, hypertension. So we now have a 6-month food and nutrition program that delivers meals, but also has a nutritionist on site to help people with more medically customized meals. Housing, we always talk about housing. We continue to make capital investments to create set-asides exclusive to Alliance. We use our vouchers. We maintain a partnership with the Durham Housing Authority, both for kind of advocacy around more low-barrier access to housing for people that have eviction and credit histories, but also recognizing that as much as we want permanent supportive housing to be the end goal for people, some people need something in the middle. And so in Durham, we have 3 of our most intensive transitional housing programs for people coming out of long-term hospitals and other institutions. And then our financial assistance program, which we've maintained since the inception of Alliance, which is our independent living. That's a rental assistance and utility assistance program to help people exit homelessness or avoid an eviction. And then our work with CIT. So this is probably one of the more exciting times to talk about wraparound holistic care because, again, you know, we are responsible for the care and coverage for treatment. Alliance has the reputation of also investing in and believing that housing is health care. And in fact, I'll put a selfish plug in. I'm happy to send a link. We recently released a 4-part video series on our work with Housing is Health Care, focusing on our work around the homeless service system. And there are several people here in Durham that you will recognize in those videos. That has probably been kind of one of the proudest things that we have done. All of our work around justice reentry, our work around people that are high utilizers of the emergency department and are admitted and discharged back into homelessness, those programs still exist. We are expanding our housing options for people with intellectual and developmental disabilities. We're talking to 2 potential partners here in Durham County to start our IDD inclusive housing communities. The state has committed as part of their Medicaid expansion reinvestment over $90 million earmarked for justice involved. That's for the state, but we continue to talk about making sure that Alliance can access some state funding, especially for some housing programs and best practice that we have presented to the state as potential funding. And then the Healthy Opportunity expansion. This is still pending CMS approval. It's also now pending the approval of the state budget. Fred Johnson has talked a lot about this work. We are very excited about this going statewide. Currently, it's in 33 counties, largely rural. We keep trying to help the state anticipate what this will look like in a rollout of its most urban counties. It's only been tested on smaller counties with a smaller community-based organization network, but we are planning for the launch of Healthy Opportunities, which will have Medicaid as a revenue source for community-based organizations addressing housing insecurity, food insecurity, transportation, although we do think that CMS will take that out of the social domain, given that LME MCOs are now responsible for transportation, and then interpersonal violence and toxic stress. Those are the 4 social domains. We are in the process now of not only engaging a network of CBOs that might be interested and have capacity for that, but funding them to understand what it's like to work in the Medicaid space. Also in that Healthy Opportunity expansion is a funding request to address gun safety. We were still at the Durham Center when the county funded Bull City United, which was kind of the first earmark of gun violence as a public health epidemic. It is still a public health epidemic, and North Carolina has requested from CMS to fund through Medicaid some gun safety programs. Again, none of this has been approved yet. There was $650 million in the initial pilots, which included $100 million of capacity building directly for community-based organizations and provider-led entities, which is kind of the broker of the CBOs between the health plans and the contracts for this. The expansion request to CMS is over $1 billion. So the state is looking to invest generously in this. And so, again, we have begun those partnerships. We've begun some investments. We have a whole team of people. Durham, through some of the county funding, we hired a community impact specialist here in Durham to begin to work with all of the CBOs, mostly in the food insecurity space, because we already do so much in housing. So that's a very quick overview of some of our community efforts. It's busy, as always. There's never a shortage of things to do. But again, our priority for this year is to really expand the wraparound and holistic care, addressing social drivers, and continue to expand our housing efforts.
Thank you, Ann, and that concludes our formal presentation. Happy to take any questions.
Thank you all so much. Commissioner Jacobs, we'll start with you.
Yeah, thank you all so much for being here. I know this is really a conversation that we should have had during our budget process, which we didn't have time for. And I think also we don't really have adequate time today, so I'm going to make a number of requests of information, but also just, I think, some follow-up decisions that need to be made by our board that I think we're going to need to have another conversation. I would just say that I think we need to do a better job of tracking the budget, because, first of all, thank you for spending the state dollars first and county dollars last. I really appreciate that. That is really important. But I think it would have been good if we had been, and this goes on all of us, tracking our budget so that we would have known during the year what was happening, so that we could have made some mid-year decisions about reallocating money. And because I know that we previously allocated some unspent dollars for the Forensic Act teams, which Eric Johnson has really helped with, I know, being part of the Stepping Up initiative, that thanks to Alliance, we're getting those Forensic Act teams going, which helps provide health care to justice-involved people. But it takes time to get these things going. And so what I'm trying to say is that we don't want to lose time, especially with, critical, all of these things are so critical facing people in crisis in our community. So I would like our board to make some very quick decisions about, because we have $5 million that went unspent this year in our budget. So I guess I'm trying to understand, I'm still not clear where we are right now going forward. with this year's budget, because for one, I am very interested in designating funding for things like transitional and permanent supportive housing. We've had a request from Threshold. They are only getting $12,500, which is really abysmal, and the amount of support that they are providing to people in our community every day, and compared to what they're getting in other communities. We have a request from them for $160,000. And their overall support in Orange County is like $285,000 or something like that, and they have a much smaller population. So, I'm looking at El Futuro. We know that they are providing a huge support for people in our community, Spanish-speaking people. Again, I would like to really understand organizations that we already know are delivering. I just had a board retreat for Lincoln on Saturday morning and found out that now over 50% of the patients at Lincoln are uninsured because they are undocumented, they are immigrants, refugees who do not have, they don't have Medicaid. So now Lincoln we have a huge funding gap because of that. So again, thinking about the role that you all can help play for helping to provide for the fees for people going to Lincoln who are uninsured. So I think there's a lot of potential. And again, I know we don't have time today to do this, so I hope that we could make some quick decisions right now, but I think we need to act very quickly, and I know Anne has been very involved with housing, and appreciate her leadership with that. I would also like and you provided some information about who's being provided services, but I'd like to understand more detailed a lot of the things that you talked about, exactly how many Durham residents are being provided services for those different programs, whether it's the housing, and then also just to make sure that you all are completely plugged in. When you mention food, are you guys working with our food security coordinator? Fantastic about the new crisis center for children and the children mobile unit. Are you all plugged in with the Rise Center that we just launched? So just making sure that we have you as fully integrated connected to what is happening is, I think, really, really important. So, and I probably need to just follow up with an email of all of my questions, but I feel like we need to have a second conversation as soon as possible.
Yeah.
Yes.
If I may, and thank you for bringing up the unspent county dollars. The way the agreement reads, that money goes back to Durham County. So I'm seeing this, and there's two buckets of this. The first bucket is we know that we have some additional money outside of the county dollars. So we're going to expand some services here in Durham based on the things that we talked about, based on many of the things that you mentioned. Commissioner Carter had mentioned to me around housing, threshold, other things. We're going to do some of those things. So that leaves the $5 million one-time money that we didn't spend this past fiscal year. If you would like us to put together a proposal based on what you heard, or if you have additional information, we'll be happy to do that and submit that as quickly as we can, and then you guys can say yay or nay on whether or not you want us to move forward. Is that something you'd consider doing?
And I personally am making a request that we put the threshold. That was something that Commissioner Burns and I were sent back in the spring, and we didn't act on that. And so that, and also looking at El Futuro as well. And I don't know enough about where we're at with that, but I know they do serve a lot of people, and are very, very effective. So Yeah, thank you. And also, I just want to make sure that you all know about the Familiar Faces initiative and are a part of that. I know Eric Johnson is a part of that group, but that is focused on people who are, there's a pilot going on with the HEART program, our Justice Services Center, and Housing for New Hope, focusing on people who revolve in and out of the emergency room, homeless shelters, and our jails. And that is another really important role for Alliance to be a partner in that.
Good.
Thank you, Commissioner Jacobs. And we have agenda prep after this meeting, so we'll have discussions about a follow-up conversation. Commissioner Carter, then Commissioner Howerton.
Yeah, this was a fantastic presentation. It's very informative for all of us, but even for the commissioner who sits on the Alliance board, which I have the privilege of doing. That's why I'm dressed in pink today, to stand in solidarity with you all.
Well, I wore pink and didn't know.
Exactly.
I didn't even know.
Of course, I didn't know what they were going to wear, but somehow, and I agree with all of the suggestions that Wendy has brought forward. So well, first of all, I wanted to say, I knew it would be somewhat troubling to commissioners to see that there was $5 million that we didn't spend, but the reason is really rather positive. For example, if the state would do their part and make the funding, distributions that are required, and that is their responsibility, then the county dollars wouldn't have to be spent in many areas, right? We're always talking about that. Education comes to mind, for example, but here's another one. And because of Medicaid expansion and increase in state dollars, we have these wonderful opportunities. And I like your idea, Rob, of bringing forward a proposal for the unspent funds. Am I understanding that correctly? I like that idea, taking into account what you've heard and what you know based on your strong local presence, and you probably know more than we know. We hear things, but we don't hear everything, and so I would really welcome that and look forward to it. I love the opportunities, Ann, that you listed on, I think, your last slide that are tied to whether or not the state approves the request for doing some of these things. And if not, then maybe we can, going forward, can use local dollars for those things as well, because they all are some of the most important things. And I also wanted to just let everybody here know that I have been so impressed with the work of Alliance in the Medicaid transformation process and in this rolling out of the tailored plan. I don't know of any other entity that really does a better job of selecting performance indicators and tracking that and just making sure that they're on target to achieve the outcomes that they need to achieve through this really complex process. So I just wanted to be sure that everybody was aware of that. And could I just lift up a couple of nonprofit support possibilities, as well as ones that have already been mentioned? I really believe in the ability of school-based mental health to really help students succeed in school. And I know that we have some school-based mental health, but I've also heard Ann over the years talk about how robust the one in Wake County is, and maybe we can do more here. So just throw that out. And Wendy mentioned the HEART work, and I know we are interested in expanding that and throughout all of Durham County, so maybe there's more opportunity there. Involuntary commitment transport pilot. I know that the people who work with HEART have talked about that, and it could, maybe Alliance could be involved there to make it happen more quickly. Also, the homeless population here in Durham is growing. The expense of feeding those who come to urban ministries, food costs have really soared, and I don't think that the operating dollars that they're receiving from the county has increased. That's on our agenda later today. Maybe there's something we can do now with some of these leftover funds to help urban ministries provide the services that they're currently providing and that they need, that are costing more and that they're trying to expand. So that's another thought. But really endorse the ideas and the suggestions that you all have brought forward for how to spend the money as well. Thank you so much.
What's positive about what you all had mentioned, it's remarkable how consistent what you had mentioned our needs in this community based on our needs and gaps assessment that we do. It's a comprehensive evaluation that we do in each of our communities to determine needs and gaps. You hit on them a lot, so that's good.
One more thing is could there be a better process for being sure that counties are aware if money is not being spent, so we, could have made decisions sooner? And maybe I missed something. I don't think I did, but I could have. Maybe if I'd been more aware, I could have brought it forward. Maybe it's a staff liaison position. I don't know, but just let's think about that.
Yes, absolutely. I think we can brainstorm about that. This year has been a little unexpected with Medicaid expansion. I don't think there was not a great estimate of how many individuals would go on Medicaid, especially from the uninsured side, because there's not any data. So the state did not change our state funding at all, and which is great because we don't want that state funding to change for years to come. So we were, in that respect, great that more individuals came onto Medicaid for expansion efforts, but caught us a little off guard because there's so many rolled off uninsured. So, but to your point, absolutely, this has definitely got us thinking about how we can appropriately predict how much state funding may shift over through the year.
So, thank you guys for being here, and this incredible presentation is always great to see you. Ann, I hadn't seen you in a while. Good to see you. And as you can see from and hear, the commissioners, there's no shortage of things that we can spend money on. So I agree with all the things that has been mentioned. The only other thing that I have not heard, and I've been seeing in the news and across the country, has to do with our schools and mental health programs in our schools, if there's anything that can be added to. I know there's a lot, but there's still a great need around that. The other question that I have, I know at one year, the state took some of your fund balance back. Is that a possibility of happening again?
Great question. It's always a possibility. I haven't heard any conversation about that. We'd like to think that our fund balance and savings that we use to reinvest is the General Assembly's piggy bank sometimes, but we're not at that stage. I think the efforts to make behavioral health services a priority for this state has helped us tremendously. That's the best part of this job, is when we do have additional money and savings, we are a government entity. We use that money to reinvest in services, and we do it all the time. So this is another great opportunity for us to expand and improve care in this community with what's left over.
Oh, great. Yeah. Thank you. Go ahead.
I was just going to add one thing. With the Taylor plan, there are capital requirements that we must maintain at a certain level, so that has certainly helped protect our fund balance as well, because the state knows that, the Department of Health and Human Services communicates that, and they have an interest in the future for us being under the Department of Insurance, so helping to protect those dollars for those efforts as well.
Okay, thank you. I look forward to you working with staff, with our manager, and bring back a proposal as to what we can use some of those dollars for.
Got it.
Thank you.
Thank you. Yeah, I want to reiterate Commissioner Howerton's question about, if the state pulls the funding, we have this $5 million, but also how does that take into consideration, like if we don't have that funding next year, and then cutting back programming,
right,
how will it negatively impact the users of the services? And then also to the point about mental health services in the schools, also, if you all haven't connected already, I know Director Jenkins in the Public Health Department has a staff member dedicated to looking into like ACEs and how that impacts our students, if that connection hasn't already been made. I think Manager Sewell can help with that, or Joanne, with making sure that y'all are connected to her.
Thank you.
Thank you all so much for your
Thank you.
presentation again.
May I ask one question? Proposal, is 3 weeks okay? Do you need it sooner than that?
Yeah, that's okay with me.
All right, we'll try for shoot for 3 weeks, and I'll send it off to Dr. Soul. And thank you for Dr. Soul. She's been a good partner for us, and she's always responsive when we have needs. And always to Commissioner Carter, great asset to our board. Thank you.
Next, we will have the presentation on the Omnibus 19 text amendment. And I see our planning department team is here. We are already running a little bit behind board, so we're gonna tighten up the ship. And we have 30 minutes scheduled for this, so 20 and 10, even less? 5 and 5, I'm joking.
I don't need 20 minutes, but we can go as quickly as possible. My name is Robin Schultz. I work for the planning department as a planner and an arborist, and I am here to present an Omnibus 19, TC 240001. Do you want to introduce yourself?
And I'm Scott Whiteman. I'm the community planning manager, and I'm here just to provide Robin moral support.
So an omnibus, as a reminder, is a set of technical revisions to the ordinance. These should generally not include any sort of larger policy initiative. The changes within this set, or this omnibus, are roughly divided into 3 categories, which are changes related to the passage of new state legislation, some corrections to incongruencies after the passage of SCAD, and some other minor inconsistencies that we needed to correct. And so within SCAD, some of those corrections were that we removed all mentions of required parking. We clarified that exceeding 20 ADUs requires a site plan. We ensured that all height calculations matched the new ordinance language. We corrected density requirements in the CN zoning district, and we clarified that SCAD did not remove the requirement for project boundary buffers when a site is mass graded. And so as far as state legislation, the updates that we've provided, we've updated the public notification requirements for street renamings. We've removed any design requirements for things which fall under the North Carolina Residential Building Code. Worth noting that that now classifies triplexes and quadplexes, and so those are now no longer subject to any design requirements. We also removed any ordinance which conflicted with the North Carolina Department of Environmental Quality's purview, specifically around wastewater systems. So this is a non-exhaustive list of all of the changes throughout Omnibus 19. It does make changes to 11 articles within the UDO. Some of those minor consistencies that we corrected were removing a duplicative definition for lot width. We corrected the annual comp plan reporting period to 2 years, which was agreed upon during the adoption, and updated the floodplain administrator definition within the UDO to reflect that it is administered by the planning director. We also included 2 clarifying additions within the definition of affordable housing. This was at the request of the JCCPC, and those 2 clarifications were that AMI averaging is permissible and that housing choice vouchers are able to be utilized for those units. Lastly, we made 2 changes to the grading setback section after a meeting with Habitat for Humanity, essentially clarifying that street frontages for sites that aren't mass graded shall not be included within the grading setbacks, and also allowing grading within the setback for positive drainage away from building foundations. So this will be going forth to you all next Monday and City Council on the 19th. That concludes staff's presentation, and we are available for any questions.
You took that 5 minutes real seriously. Thank you, Ron. Start with Commissioner Carter this time, then Commissioner Jacobs.
Yes, thank you so much for this work. I think my only question really is, there was some mention, maybe in your memo, that this was approved by the Planning Commission. There was one planning commissioner who didn't approve it. I have no idea who that is, but we often see their comments. Just wondering what was the reason.
Yeah, so that was from Commissioner Cease. He had a question around ADUs. Essentially, the language is changing within Omnibus 19 because SCAD changed the allowance for accessory structures. Previously, they were only allowed behind the rear building line. SCAD changed them to behind the front building line, which allows for ADUs within the side yards. So we're removing that portion of the ordinance which says that they can no longer be in the side yard because an ADU is an accessory structure. So we just want all of that language to match.
Makes sense.
Yeah.
Yeah, thank you. Thank you for this work and presentation.
Commissioner Jacobs?
Yeah, I just had a follow-up around, could you talk a little bit about what Habitat had specifically requested, a little bit more about that and why?
Yeah, so essentially what they were saying was when they were developing multiple infill sites, that they were having issues essentially along the street frontage, which those grading setbacks for those infill sites were mostly input into the phase development and grading standards as a result of public input and guarding those adjacent neighbors. So grading along the street wasn't really fulfilling the same intent of the ordinance, so they were having some issues with that. And then as far as going within the setbacks for positive drainage, they were having issues not being able to sort of construct and having water drain towards the structure.
Okay, because I know, this is, I think, one of the challenges of infill development anywhere, is when you come in and then, what do you do about drainage? And the impact when removing trees and all the ways that we naturally get the absorption of the groundwater, the stormwater runoff. So, it just seems like this is a challenging issue. This is something that we often hear complaints about for any kind of development, right? Is that the negative impacts that can happen afterwards with runoff. So I don't know if you I don't know if we're doing anything. Do you feel like with this omnibus, are we doing anything to help with that, actually?
So I will say within an omnibus, technically they go much quicker than a normal text amendment, right? So like with the phase development, we met with like multiple community members, et cetera, et cetera. Like it has a much larger public engagement than an omnibus. It's supposed to just be smaller technical revisions so that we can get them through faster and the ordinance, is more efficient. I think that obviously this is a huge part of something that needs to be addressed during the UDO rewrite. So I think our intent with this omnibus is to make this small technical change, make the UDO better while they're sort of rewriting it. We will be moving into the development standards portion of the UDO rewrite within the next few months. So I think that's probably more where we'll have more opportunity to sort of think about those things.
Thank you all so much.
Thank you.
Okay, that brings us to our next item, which is the benefits update. And I believe I saw Attorney Everett Perry in the back and her team. There you go.
Good morning. I'm Kathy Everett Perry, Human Resources Director, and this morning we have with us our benefits brokers who will give a presentation about our new plan design and answer any questions that you may have. We have John and Alex, and Deidre Gonzalez, our benefits manager, is on Zoom to answer any questions. So I will turn it over to Alex.
Good morning. Great to be here. I'm hoping to kind of give an update with some historical context on how we got to the current plan designs for the employees of the county. High level, the county has a self-funded health plan. What that means is we hire an administrator, and we're the independent consultants consulting on the health plan. I'm Alex Doberstein. We hire an administrator to pay the claims to the provider providers, but the actual claims are paid for by the county. So when we are looking at the cost, we use the terms kind of projections a lot because we don't know what the actual claims are going to be until after the fact. So, the employees will pay a copay or deductible, which is a portion of the cost, but then the major expense is billed to the administrator, then paid for by the county after the fact here. So we're going to take a look at a little kind of the history of how we got to where we're at today. So IBA was hired as the consultant back in November of this past year, which is after the renewal that took place for July 1st. And there was some information that was used on the projection from the previous consultant that was using some outdated data or some incorrect information or incorrect presumptions, but they anticipated that last year was going to be a flat renewal, so the same as the previous year. But in the actuality, what happened was there was a significant cost increase. So we ran about 25% over the projections, and we're talking about for some big picture, about a $30 million budget on the health plan claims. So 25% of that is kind of a $6 million unanticipated deficit on the health plan. Some of that was, there was anticipated big cost savings by changing the pharmacy benefit manager. They were projecting like a $1,750,000 total plan decrease by making that plan. In practice, pharmacy spend went up over $1 million, which was a big portion of that miscalculation. And then they had some incorrect numbers that weren't matching what the budget was actually paying out or what the TPA was saying. So we're not sure where those numbers had come from, but in all, it created a pretty significant budget deficit for this year.
Just TPA and PBM.
Sorry, yes. TPA is the third-party administrator, and this, for the county currently, it's Cigna, which is a big health insurance carrier, and a pharmacy benefit manager is a PBM. They're the organization that managed the prescription drug spend. And now that had moved to Cigna this year. So now Cigna is both of them. But once again, they are the administrator of the plan. Yep. A pharmacy benefit manager. So they're the ones that determine which drugs are on the formulary, what's covered, what's not covered, what tier they fall into, and then they get rebates back from the manufacturers that offset total plan costs. It's the third-party administrator. So in this case, it's Cigna for both of them, who's a health insurance carrier as well, but in this case, they don't take any risk on. They are simply administering the plan. And then all claims under a stop-loss threshold of $225,000 per person is the responsibility of the county. So all claims that are paid out are just really coming out of the funds, the general funds there. So we're started off in a pretty big deficit going into this renewal. So then when we took a look at utilizing the most recent claims information and projecting what the 2025 renewal would be, we are calculating at an 18.8% increase. So that increasing the amount of budget in order to cover future claim costs for the current plan year, which is equated to about a $6 million spend. And I'm trying to keep this high level to try to keep it able to be understandable, but any additional backup details on this, we monitor every claim and have it all in dashboards that we can send to you. Yep.
Might be at a high level,
Sure.
so that we can follow you.
Okay. All right. You mean while I'm talking through this? Okay.
So when you say call for an 18.8% increase, my minute question would be why?
So when we look at the current utilization and kind of estimating what the next year's cost is going to be, so when we set our budget, we're trying to determine how much claims the county is going to be responsible for the next full year, right? So we're trying to estimate how many people are going to be going to the hospital and what their claims are going to be throughout the entire plan year, so all the way until June of next year. So when we're estimating what those costs are going to be on a monthly basis, we utilize the most recent information to project what the actual cost will be. Is that okay?
Let me just say,
Yep.
What we usually do is we take a look at the most recent 12 months of claims, and we take a look at the claims that are both pharmacy and medical claims. And a medical trend today is running right around 9%. So even if we had $1 that we spent in the budget to cover all of the claims and administration and the pharmacy, you would look at around a 9% increase. If we were less, and if our loss ratio was maybe 90 cents in our claims, then we could probably look at maybe having a 1 or 2% increase. So based on what Alex said earlier, the previous consultant that you had underrated you for that particular renewal. And what happened is we had more claims than expected in that 12-month period of time, which resulted in the 18.8% increase. And that also included the rebates that we got from the pharmacy benefits manager, and we had probably close to, I would say, $3.5 to $4 million in rebates that helped offset the cost, that helped reduce those particular claims. So based on the claims that we had, for both the medical and the pharmacy and the trend, we came up with that 18.8% increase. And then we'll show you the next steps that we took after that. Did that help any? Okay.
Thanks, John. So when we were trying to make that 18.8% projection get into a more tolerable number, we considered several different options. One of them was reducing the coverage or services, so having more things be excluded from the plan, or reducing what's covered and not covered to try to cost shift. Decided that wasn't a good option. We looked at access to care, going with a more limited network, saying you can only go to these providers because they're less expensive. That wasn't that tolerable. Vendor changes we considered, you moving away from Cigna, but based off of disruption and some of the contracts, exit clauses, that wasn't a viable option for this year. So then we were really left with plan design changes and the contributions. So the plan design is how much the member pays when they utilize the services, so a copay, or if they need to go to the hospital for hospitalization or for surgery, they pay a deductible, and then the contributions, how much do they pay out of their paycheck each pay period to be enrolled on the health plan. So that's what we really were left with when we decided we really didn't want to disrupt people when it comes to access to care or the type of services they're able to receive. And to help make an informed decision on that, we did do some benchmarking that I'm going to take you through a little bit so you kind of get an idea of comparable to peers here. Another thing we did was the stop loss. So that's kind of the one insurance you do purchase is the for these high-risk claimants. So when there's someone that has a very catastrophic year, that is not on the county, that's on the stop-loss insurance company. So we took a look at going to different vendors, and we were able to really get a very competitive proposal to bring that number down significantly. And then we increased the deductible a little bit because when we did the modeling, there was cost savings in that. So we did do that, which brought down the renewal by $550,000. And then ultimately what we decided on a plan design was that it was really important that we maintain a plan that for employee only, they don't pay anything out of their paychecks. So there's still a plan that's a $0 contribution plan. We know with inflation and the cost of living going up for everyone, it was important that we weren't giving raises and then taking it right back through increased contributions. So that was a priority is keeping a free health plan, but in order to do that, we had to increase the plan design. When the employees are going to pay a copay or deductible, we had to increase their out-of-pocket costs. We also then allowed people to buy up. So someone that is a high utilizer of the plan that wants to maintain a very rich benefit plan design, they have the option of doing that. They're just required now to pay contributions towards that plan. So for employee only, that's about $70 a month to buy up to a very rich plan design. And then we did consider an option that brought the renewal to a projected 11.3% increase, but it was a financial decision that we really had to try to keep it within that 8% number just to be fiscally responsible here. So we really kind of brought the plan design to that level to be able to get within an 8% number, anticipating that there would be some noise from employees knowing that they have increased either contributions out of their paycheck or increased plan design costs there. So that was anticipated, but it was just really a big priority to get within that 8% 8% number. So on the benchmarking, just to make we wanted to make it an informed decision on our plan design. Previously, it was a $750 deductible, what would be considered a platinum plan design if it was on the individual market, so a very rich plan design. How did that compare to the peer group? The peer group we look at is the state health plan, all 10 of the largest counties by their population, and then 8 of the 10 largest cities was kind of the data set that we were able to compare it to. And you can see we were at, this is the number of plans that are offered. So who offers this option of buying up or not? You can see the green dot represents where the county in this chart. So 74% of the peer group do offer multiple plan design options. So we were in the minority of the 26% that offered just a single plan design option at the time. Before, yep. So now we'd fall into that the orange bucket of 2 for the current year. So this was the previous plan design. So the deductible, we took a look at for the different counties and local governments that offer multiple plan designs. We benchmarked the lowest cost option, so not just the buy-up option, but kind of for the lowest cost contributions where the plan design fell. And you can see there's a couple that we're the green on the chart there of a $750 deductible. So this is if you're hospitalized, how much you would pay for the year for that hospitalization or for the surgery. And you can see we were on a very rich plan design there with a $750 deductible, and then the orange triangle represents where we fall on the new plan design. That moved all the way up to a $2,250 deductible. So we're still not the lowest, but we are more on the further right side of the chart here.
Just to be sure I'm clear on this, the green Durham County 750 is what previously we were before we made the changes this year. The orange triangle is where we are now. Everybody else is where they are now.
Well, this is the dates of that one, going back one slide, sorry. So, nope, 2 slides. So these are, some of them were the effective dates of January 2024. So most of them are in that. Some of them were 2023, which is like the most recent available data we were able to get on that.
Okay. Okay. And just comparing to the city, it is now 7/1/2024. Yeah.
Yep.
Okay.
Yes. Yep.
All
That's
right.
the most recent one for the city.
But some are 2023. So yeah, they may have changed so that actually we might compare more favorably now if we knew what they were in 2024.
Right, or they're coming up on a renewal for this year, right?
Yeah.
So.
Right. As increases occur for us, they might have occurred for them, and they also had to.
That's true. Yes.
Also, the slide that has the orange triangle, what is the number?
For the base plan design, it's $2,250 now.
Okay, I just want to say that it would be helpful to actually have the number, and not just an orange triangle.
I have the printout of the full plan designs, if that would be helpful.
Well, maybe you just, when you describe it, you could say what is the number that's represented by the triangle.
Okay, will do.
So is that the deductible that the employee has to pay?
So that's if they were to have major services, so going to the hospital, or if you're going to have a baby or surgery, through those major services, that's when they would pay that deductible, and that would be the member's cost share on that. If you're just to visit a doctor or your prescriptions, then there's a copay, so like a $10 copay or $20 copay, depending on where you're getting that done. But for the hospitalizations and major services, that would be the member's responsibility.
So this is compared to what has it been, say, in the last 5 years? What is the increase over time?
Would you be able to speak on the history? I think that it's been $750 for quite a while, yeah.
Yes, it's been $750 for at least the last 5 years.
Yeah.
So the last 5 years, and now it's gone up to 3,000?
$2,250.
2,000.
And that's for the free option. For someone that's thinking there's a good likelihood they are going to need to pay a deductible, they may have the good chance they have a surgery or ongoing condition that results in them having to have major services, they have the option to buy up to a $1,000 deductible plan.
But Alice, can you explain the deductible? The deductible isn't every time they go to the hospital.
Right. Oh, that's an annual. Thank you. Yes, that's an annual deductible. So once you've reached your deductible for the year, it could be multiple procedures that gets you up to that. At that point, it's cumulative for the year for all of your spending up until you pay $2,250, and then there's some co-insurance after that until you get to an out-of-pocket maximum of $4,500.
And then the rest is on the county.
Yep.
So what is included in that? Is that just a deductible? Is that money, is that for the hospital, the doctor, or are there other fees involved in that?
That's like, I may try to.
I know that when you go to the hospital, you have to pay a deductible. I got that.
Right.
I'm just trying to follow the cost
Sure.
accumulation here, because this is almost tripled in
Right.
cost. So just explain that.
You go to that third slide too. I'm from old school. What I used to do is tell people, once you go to the hospital or any outpatient or inpatient care, you have to meet your deductible first.
I understand that.
And then this $2,250 deductible is for the plan that the county offers with no payroll deduction for your employees. And so we had a zero plan there. And it's the first year we put in what is called a dual choice. So we wanted to keep another rich benefit out there. And so we added the second dual choice, we called it a buy-up plan. And that buy-up plan had a $1,000 deductible with a $2,500 out of pocket. So going back to the $250, once you've met that $2,250 at the hospital, and most times when you go to outpatient care and go to the hospital, you're going to meet that $2,250. Subsequent to that, it's 70%, right? 80. Subsequent to that, the next bills that come out of the hospital, you pay 20%, or the employee pays 20%, and the plan pays 80%. So if we took a look at a plan, after you met your $2,250 deductible, then let's say there's an additional $10,000 in bills. Out of that $10,000 in bills, you pay 20% of that, or $2,000, and then Cigna pays the other $8,000. And then once that $2,000 reaches a maximum, along with your deductible, which is $4,500, then the plan pays 100%. So any catastrophic situation you have, the only time that you'll pay, the amount of monies that you'll pay out of pocket would be $4,500. Okay, and on the buy-up plan, the out-of-pocket maximum will be $2,500 in the event of catastrophic situations.
Okay, and I guess what I'm still hearing is an extraordinary amount of increase on the employees, that's what I'm hearing. Now, am I wrong in that calculation?
What was the out-of-pocket with the $750, you remember?
It was $2,500, and so for the people that buy up are paying the $70 a month, that did not increase at all. We kept it the same. For the people that are on the free plan, that is going up by $2,000.
That's what I thought I heard, yeah. Okay. Yeah.
And the reason is because the cost of the county has increased 18%.
Well, that's a very good point. We bring in the information. We meet with finance, and finance tells us, wow, we need to really take a look at our budget, and we really need to try to get the budget a little bit lower than the $6 million. So we went out and they said, here, let's take a look at changing the deductibles, changing the co-insurance, and come back and let us know what that decrease would be. We came back with that particular decrease, and it came out to be from 18.8 down to 11.1. And finance, when we were meeting with finance, they said, can you get it around 8%? So we went back to the drawing board and see what else we can shift the cost over through deductibles and co-insurance. And this is what we came up, and they accepted the 8%.
And for clarity, it was budget instead of finance. Yeah.
Yeah, I'm sorry. Thank you. Sorry about that.
And we know how convincing Keith can be about reducing the budget. So John did go back a couple of times to try to meet the expectations.
And just, I'm trying to think through how people make decisions about insurance and how insurance works. And so an employee who is, young, healthy, all of that, they may think, well, I'm probably not going to have very many medical procedures at this stage of my life, and I'd rather have more money in my paycheck, and so I'm going to stick with the plan that is $0 in the quote contribution category. And for the healthy employee, probably they won't see much of an overall increase. Am I thinking about it right?
Correct.
Yeah, that's perfect. And the other thing, one additional thing is, since it's 0, if they have any kind of family members or a spouse, the payroll deductions will be significantly less than the buy-up plan as well. And so the affordability, we will get more people on an employee spouse or employee child, children, and family on that lower plan because the payroll deduction is lowered.
And I want to be mindful of the time for your presentation. I know you guys have some slides left, so if we can try to let them get through the slides.
Okay, great questions, though. I'm glad we're getting an full understanding on it, though, so we appreciate the questions. So similarly, this is the out-of-pocket maximum we've been talking about. So previously, it was a $2,500 deductible and not labeled on there, but it's on the base plan, it's $4,500, as we said. So this is all your co-pays, all your deductibles, all your co-insurance, your worst case for the year has gone up from $2,500 to $4,500.
And remember, this is for the 0 plan. For the buy-up, we're still at the green level.
Yep, and still less the city there. And co-pays, this is a very busy chart, but just know that we've moved from being the lowest co-pays to kind of middle of the road compared to the peer group there. So this is when you go to the primary care or the specialist or an urgent care. Now we're more in the middle tier there. And then prescription co-pays, previously it was $0, and this is for generic prescriptions. Now it's a $10 co-pay on that. But here's the other big part of it, right? So we're top plan design and then contributions. So this is out of the paycheck. It was important to keep that $0 contributions. We're one of only 4 local governments, of the peer group that has a $0 contribution plan. So we considered, having people have to pay for it, which then is you have people opting out of it. Oh, I don't want to pay anything for that, and then they are unable to get medical care, or have full coverage. So really important, just from the mentality, recruiting, and just people's feelings about that health plan, to maintain that $0 coverage was the decision that we made. And that's part of contributing to why we had to increase the deductibles and out-of-pocket maximum so much to be able to maintain that and get within our budget number of 8%. But we were able to do that, so we still have a $0 plan there. So kind of looking now, where we're at today, so the question was proposed on how much would it cost if we were to go back to a single plan design option, not have such a high out-of-pocket maximum and deductibles, really kind of get the member costs back to if everyone was on the buy-up plan. And I just want to, part of what we did is we changed the plan design from the expected actuarial value, which is basically how much we anticipate the employer paying versus the employee paying of their total medical cost. Went from like an 89% down to an 81%. 81% is still considered a gold plan, if we were comparing it versus, other plan designs where someone would purchase it as an individual or another employer. So still very good, but we were at a platinum level. So we dropped it down to a gold. We're saying, okay, if we bring it back up to a platinum, what would it cost? So there's two factors to that. So just running through the cost of now the county absorbing all of the, having a lower deductible and all that, the total expected claims is $1,850,000 that we would be reabsorbing as the county rather than cost shifting it back on the employees. The other factor with this now, though, is that you had 28% of all the employees decide to buy up to that richer plan design right now. And if we were to just eliminate the lower plan and move everybody to the higher plan, we couldn't continue to have those employees paying more. So then we'd really have to refund back all the contributions and revise the budget based off of that. And that would be an additional $640,000. So when you combine those two, we're at about a $2.5 million increase to kind of move back to that single plan design. The other item I just felt responsible to bring up is when we were doing these plan cost projections back in March, April, May of this year, and unfortunately the claims have continued to trend higher even since then. So we typically see claims where they kind of go up and they go down, kind of cyclical, but we see claims continuing to rise here. So if we were to take the most recent claims data that includes the month of May, that we had an unprecedented over $4 million in claims come in for the month of May. Using that and the most recent claims data, if we were to project out how much we are going to be spending on the medical budget, we're at an additional $2.5 million budget deficit over that 8% what we had budgeted. So additional $2.5 million of claim costs. So to move back to the single plan design option of putting everyone on the high plan would be $2.5 million. So if we just had a one-time, hey, we're going to absorb it and do that, our concern is we are going to be in the same situation come next year's renewal, or even worse, just because these claim costs are continuing to rise here. Part of that is just because we have such a rich plan design. I think we're attracting people that really value the health insurance, or coming to work here and wanting to stay here. So having such a rich plan design is kind of attracting people that really value the health benefits. But on the claim side, that's really hurting our utilization, where we're still seeing high claim costs on top of just general medical trend, cost inflation, and some new prescriptions that are really, we're spending a lot of money on. So all those are kind of adding up to a situation where we're concerned about the ongoing affordability of this health plan and being able to still offer great benefits here. So sorry, not happy news, but I wanted to be thorough and honest about the current assessment of it, but happy to answer any questions. I know we answered quite a few as we went along here.
Thank you so much. If it's okay, I have a few questions I want to start with. For Kathy and I guess Dr. Sewell, so the cost increase you're saying to go back to the platinum is the 1.85?
For just the plan design, yes, but you'd have to do something with the contributions, because right now there's people that are buying up 2.5.
2.5.
Yeah, sorry.
Okay,
Yeah.
no. So then we had gotten that email of wondering that said that the cost increase would be, it was like 475. What was that about?
I think we were looking at, you talking about the bonus options?
Well, there was the undoing the tiered benefits plan cost was 400,000.
And so that's why we went and asked the consult IPA to take a look at it. That was something that budget looked at, just at really the claims, the amount of the contributions that we would no longer get is actually $640,000 and not $400,000. So the
in addition to the $1,850,000.
So I think what we were looking at on the email that was sent to us was the amount of the contributions that we would no longer get from employees, but it's actually $640,000.
And then what was the note, the 1.3 million already available?
So if you recall, during our budget discussions, we did put in a placeholder for $1.3 million what we were looking at was doing bonuses to employees or some type of additional compensation to help cover some of the out-of-pocket costs for the premiums, the increased premiums. So we do have $1.3 million that we were planning to provide to employees to address the additional
To
premiums.
return to the platinum, we would then need to find 1.2.
An additional
Okay.
$1.2 million.
And then one thing I was hoping for also from this presentation would be how it's been actually impacting our employees of their pay. Like, I've heard from staff that even with the COLA increases, these medical plan changes have actually lowered their overall monthly paychecks. So I wanted to see if we can pull that together and if that can be emailed to us as soon as possible of how many employees are being impacted in that way. Because I would assume that it's happening to our lowest income employees here at the county. And then also, and I know this isn't the intention, but what I fear is that with the looking at it of, and this isn't a hit at you, Commissioner Carter, I'm just using your example of like the youngest employees make the choice to not, young healthy employees make the choice to not buy up. But I feel like this plan can in a way be not punishing, but hurting our employees with chronic health conditions by having to make the decision. Like, they don't really have the choice. They have to buy up because they know they have this chronic health condition that's going to require. And I feel like that's unfair to them to be pushing that onto them. That makes sense. Those are my concerns are.
I think we shared something with you all prior to the budget adoption with the lowest paid and the impact of the cost, but we'll look at that again and see if we were correct.
Thank you.
Okay.
And that's what we were looking at doing with the bonuses, to give the higher bonuses to those who are in our lower pay bands so that it could help recover some of the premium costs that they are now paying towards the plan. Yeah.
Commissioner Jacobs.
Yeah, thank you so much for this presentation. This is really helpful, and I wish we had actually had this during the budget and when this was, really brought forward, because it helps to understand kind of the bigger picture of what we're facing. And I also think it's important that this is shared out with all of the staff. I feel like this is a financial crisis that we're in, and in the bigger context, I saw the email that the manager shared with us that came from the budget office. Thank you, David and Keith, wherever you are. Because we do have a fiscal responsibility to keep the county on sound financial standing, and so this is part of a bigger issue, but I think that we have to be very mindful going forward, and lessons learned. What can we learn about how we did make this transition, I think, and I thank you for, I can tell that you've really worked hard on this, but it's really important that we are bringing all of the employees and the staff along in the conversation, as well as our board. So going forward, I would even say, like, we should be starting now. It's kind of like with the budget. We need to be starting now, talking about what is coming, and making sure that all the staff get involved and have input in understanding that we can't keep doing the same things the same way we used to. We just literally can't afford it. And what do people want to see? What do they prefer? And so I think it's going to be very important that we get that input from every level of staff. I think that, clearly looking at where we were, for instance, last year, we were a complete outlier compared to other governments, and that's not sustainable. And I think, looking at something that we can come up with short term to help this transition, I guess, the manager talked about, especially looking at the employees who have been the most negatively impacted, our lowest paid employees, looking at something we can do to help with this year of transition, but then knowing going forward that that's not, again, it's a transition. So I guess I look forward to hearing some options to help with the transition within our budget, but also that we really start now with you all having conversations, if possible, in small groups or whatever, with our employees so they can understand what is going on and be able to, again, say what they want, and that we can do our best to try to address that. So that's all I'm going to say. And again, appreciate getting this information right now. Thank you.
I have one more question. This is regarding the retirees. Can you talk a little bit more about the increase in their deductible that they would need to pay?
Are you speaking of the pre-65 retirees that are on your group health plan?
I'm not sure. I just know that what I understand is the retirees are having to pay more of a higher deductible, and that's all I know about it.
That would be for our pre-65 who stay on the plan, but once you reach the age of 65, our retirees go to Medicare. But
we changed the plan, though. We put them on a high plan, so they don't pay anymore.
right.
Yeah, the decision, because of the noise and looking at that population after the renewal, the county actually made the decision to kind of grandfather the pre-65 retirees onto the buy-up plan. So they have, the richer plan design, so they weren't negatively impacted. So that segment of the population
So
grandfathered.
in essence, the pre-65 retirees were grandfathered the high plan with no additional monies out of their pocket for the premiums.
Okay, thank you.
Yeah.
Mr. Carter?
I just want to say I agree with everything that Commissioner Jacobs had to say about the importance of this information and how I have a greater understanding of the rationale for the change, and hope that it would help employees understand it as well. It does seem necessary to me. A couple of the other boards that I sit on as a commissioner that have budgets as large as the county's budget, when the insurance costs go up, they don't continue to absorb those because it's unsustainable, and I just see that have to be passed along at some reasonable level, and just trying to strike that right balance, which is, I know, what we've all been working hard to do. And if there is some way of providing some immediate relief, I mean, I would be in favor of looking at just salary increases, as we do every year, as a way to make it more affordable for staff. But we have a good benefits plan, a really good one. The 81% actuarial value is still so great, and it is a recruitment tool, to go along with our salaries, which are also getting better for publicly paid workers. So just thank you for the work and all the information, and thank you, Kathy. I know you all and your team have worked really, really hard on this as well. Really appreciate it.
Thank you all so much. Appreciate it. Okay. Now we have our lunch break scheduled. If folks can take, sorry? I have to pump. I have to take a pumping break, so.
It's also the baby's lunch break.
Yes. The cow needs a break. So 20 minutes, 20, 25 minutes, folks will be back. Thank you.